Hey everyone, this is Michaela Vermeulen and I am an adult acute inpatient clinical nurse educator at Alberta Hospital Edmonton. I'm going to tell you about two initiatives that you will be seeing implemented into our inpatient settings in the coming weeks. The first is the LOCUS tool and the second is the Almost Home initiative. We will be reviewing what these concepts are, how they are meant to improve the quality of care we provide to our patients, and where you will see them implemented in the care you provide on the unit. So every new initiative or tool is developed to fill a need or address an identified gap in service. Based on data obtained from 2019 to 2020, readmission rates for individuals accessing addictions and mental health services was 10%. Emergency department presentations were around 27%, and no-shows to follow-up appointments was around 21%. Based on past research, we have identified that patients are at the highest risk for suicide in the weeks immediately post-discharge from an inpatient unit. As many as 6% of all suicides by discharged patients occurs within the first week post-discharge, and approximately 20 to 21% occur within the first 3 to 12 months. Furthermore, hospitalizations and time spent in the acute care system is more costly than care provided in community-based settings. Connections with appropriate and clinically indicated community care would negate the need for readmission to hospital. High dependency on hospital-based services has led to an increase in current bed pressures and extended community follow-up wait times, which has the potential to create an unstable discharge environment for our patients. These increased levels of risk for both suicide and deterioration can be mitigated by having an earlier intensive community follow-up that tapers off gradually to transition into community-based care. We believe that this transition work can start on the inpatient unit. So currently, about 30% of all hospitalized patients experience a gap in care during their transition from hospital to home. Gaps in care can result in accelerated progression of disease, hospital readmissions, and increased healthcare system costs. So they're waiting for things like discharge plans, follow-up connections with community-based mental health clinics, test results, and referrals to new service providers. Referrals are largely based on what knowledge an individual clinician has of services within the Edmonton zone, the relationships they have, and what has worked in the past. This is defined by homogeneity of practice. In other words, doing what we've always done because that's how we've always done it. In reality, what we've always done doesn't always mean that it will work out the way it should. This has resulted in inequitable access to services and a lack of consistency in communication and sharing between programs. Did you know that based on a report from April 19, 2021, the wait times for mental health therapists within the city of Edmonton is currently anywhere from 31 to 64 days? I know what you are probably thinking, or at least I am, that to go from being an inpatient on one of our units where there is a high level of support from the healthcare team to a home environment where there is very little means that patients wait for over a month for their next service provider. So we can begin to see why patients are at such a high risk for suicide and deterioration, leading to representations and potentially readmission to the hospital post-discharge. We need to be intentional about discharge planning and ensuring patients are supported throughout their healthcare experience. So the LOCUS tool and Almost Home initiative aligns with the AHS mission to provide a patient-focused, quality health system that is accessible and sustainable for all Albertans. Our goal and vision is to have a system that is responsive to the needs of our patient population to ensure all individuals accessing services within the addictions and mental health system are appropriately matched to services based on their presenting needs, while also balancing individual preferences. The gap that these initiatives address will include intensive outpatient and transitional programming, and intentional structure addressing patient plans to transition between services and remain supported in the process, and increased patient involvement within the hospital setting. Regardless of the referral source or point of access, all individuals will have access to the same menu of services based on their current needs. So let's start with LOCUS. LOCUS is a clinical decision support tool created by community psychiatrists initially in 1996 to guide level of care decisions. It uses information gathered during an assessment to score 6 dimensions and make a recommendation regarding the level of service intensity that is required for each individual. This information is used in combination with clinical judgment and patient choice to match the patient with the most appropriate service. This tool is not diagnostically driven, so it does not look at the diagnosis of the patient, but rather looks at the person's current needs and recognizes that some individuals need similar treatment models, even with a different diagnosis. The right service at the right time will improve health outcomes. The LOCUS tool enables the clinician to match the patient to the right service at the right time in collaboration with the patient. The LOCUS database matches level of care requirements to a variety of available and existing services. This enables us to engage the patient in determining the services that they are willing to engage in and takes into consideration the patient's choice. LOCUS provides a recommended level of resource intensity based on the current need of the patient. This can help us to have a more informed conversation with our patients about what programs we should be considering to best support them. LOCUS provides program level data that will be used to inform case management, improve flow, and increase program capacity. It also helps us to identify gaps in the system. The initial focus of LOCUS is currently on adult programs within AHS and Covenant Health. At present, referrals and consults to these programs will continue as per the current process. So the LOCUS tool will be completed at all entry points to the system and points of transition between services within addiction and mental health services. This work has been done with our AHS community services and is being expanded to other community partners, such as primary care networks, to understand the LOCUS tool and to promote a common language around service needs across the organization. This tool will continue to support the patient by being connected to high quality care that is matched to the current need of our patients at all stages in their healthcare journey. LOCUS will work in combination with a comprehensive database of our services categorized by intensity of services provided. This will help us plan and provide patient-centered care and identify gaps within our programs to ensure that we are providing the right level of services based on each person's needs. So what are the scoring dimensions? The LOCUS tool is completed by allied health staff members who score the patient on these 6 dimensions. Each dimension has a 5-point rating scale from 1, which is a minimal problem, to 5, or an extreme problem. Staff score the patient based on where they fit the best within these categories. So these include risk of harm, which includes both suicidal and homicidal risk and impairment of perceptions, judgment, or impulse control that creates danger for the patient or others. Functional status measures the person's ability to fulfill obligations at work, home, and school. This also includes someone's ability to interact with others, neurovegetative symptoms, decision-making skills, appearance, and hygiene. Comorbidities, which looks at medical, substance use, and mental health disorders. The recovery environment, so this looks at both the level of support and level of stress in the patient's home environment. Treatment and recovery history, which includes historical information to examine past exposure to and use of treatment and past history of maintaining recovery. This dimension acknowledges that a person's past experience can provide some indication of how that person is likely to respond to similar circumstances in the future. And finally, engagement and recovery status, which includes both the patient's understanding of illness and treatment and their willingness to engage in treatment and recovery. A score is given to the patient based on how they score as a whole while taking into account each of these categories. This score helps us to match a person to a level of service and service provider that would be most appropriate to support their current needs, and can help guide our conversation with that patient and their support people about that transition of care. Allied staff have access to a LOCUS tool generator that helps to point them in the direction of services that may be appropriate for each patient. This LOCUS worksheet is an example of how the tool is scored. You can see that each of the dimensions are rated on a scale of 1 to 5. Each of these scores are allocated based on a comprehensive evaluation parameter definitions that staff learn more about when they do the LOCUS training. While it is not mandatory, there is a 3-hour My Learning Link course if you wish to learn more about how scoring is done. So I know this is a busy slide, but this pyramid gives us an idea of how a patient's LOCUS score translates into the level of support that they require, as well as some of the services associated with each level. So you can see at the bottom of our pyramid a level 1, which provides treatment to clients who are living independently or with minimal support in the community and who have achieved significant recovery from past episodes of illness. This could include programs such as Grey Nuns Outpatient Program or other types of community-based services. Level 2 provides treatment to non-complex clients with mild to moderate symptoms who typically have one presenting issue and have a fairly supportive recovery environment. Treatment and service needs do not require intense supervision or very frequent contact. This could include outpatient ECT programs or other outpatient clinics. Level 3 provides treatment to clients who need intensive support and treatment, but who are either living independently or with minimal support in the community. Service needs do not require daily supervision, but treatment needs require contact several times a week. Traditionally, clinic-based programs could include EPIC, day hospital, or the opioid agonist treatment clinic. Level 4, which includes services provided to clients capable of living in the community, either in supportive or independent settings, but whose treatment requires intensive management by a multidisciplinary team. Services include partial hospital programs and assertive community treatment programs such as diversity, day hospital, ACT, and urgent psychiatric clinics, for example. Level 5 refers to residential treatment provided in the community setting. So care is traditionally provided in non-hospital, freestanding residential facilities based in the community, such as the Addictions Recovery Center or Henwood. And finally, level 6, which is the most intense level of care on the continuum, which includes services that are traditionally provided in a hospital setting. For us here in adult acute inpatient, this is where we fall in the pyramid. So if you take a look at the top right-hand box, most of these programs, such as day hospital, forensic services such as COAST and FACS, can support our clients at more than one level of care. So as you can see, the LOCUS tool helps us to create a moving picture of what the patient needs over time and provides a common language and format for communication at points of transition. So you will see the LOCUS tool being completed on our inpatient units, usually within about 7 days of patient admission by our allied health members, and entered into the patient's rapid rounds, care plan, and clinical documentation. We do this scoring upon admission to identify whether or not the patient actually needs the level of care offered by an inpatient setting. This helps us to identify gaps within our system so we can make changes and improve our community care support to meet this need. Patients are often admitted to hospital because there are no other options for care available. It is important to identify these gaps when and where this happens. Our allied health team members, such as social workers and occupational therapists, have been trained to assess our patients with this tool upon admission, and anytime there is an acute change in the patient's condition or a transition in care is being considered. The patient will be scored again 2 to 4 weeks out from discharge ideally, and to ensure they are being matched to an appropriate level of service. So remember, the goal of this tool is that it provides us with the ability to critically and objectively assess our ability to match the appropriate level of services for each individual patient. So this tool supports our clinical judgment and encourages a measure of standardization in how level of care decisions are made across the zone. We can better plan for patient's discharge if we know what we are looking for. Patient-centered care involves effectively planning for the needs of the patient. Contrast this with provider-centered care, which currently includes doing what we've always done because it's easy. So tying this in now to our Almost Home initiative, due to the COVID-19 pandemic, there has been a decrease in patient activation and engagement activities on the units. This is yet another barrier to recovery and stabilization. The Almost Home initiative fosters a stronger connection with our community service partners in order to support a patient's transition back home. The goal in this is to facilitate a safer discharge environment and can also improve flow and patient accessibility to services across the mental health continuum. Along with more intensive outpatient services such as the day hospital, patients will be better equipped to remain in the community longer, thereby reducing wait times and a patient's risk to decompensate. Our goal is to reduce risk, decrease rates of suicide, and set patients up for success with safer discharge planning. We will focus on connecting the right patient to the right service at the right time. So what does the Almost Home initiative consist of, and what can you expect to see on the units? Well, there will be an increased emphasis on the provision of on-unit groups, community groups, and connection with peer support. This work is currently ongoing and differs unit to unit. Potentially, some of these groups can be supported by community providers. Patients will be encouraged to administer their own medications that will be stored by nursing staff on the unit. At Alberta Hospital Edmonton, patient medications will be kept in blister packs provided by pharmacy once the patient has been stabilized on their medications and is enrolled into the Almost Home stream. This may vary site to site. Patients can be assessed by programs such as the day hospital for an intake assessment pre-discharge. So if the patient is a patient at a facility other than Alberta Hospital Edmonton, a day pass can be considered for these patients as part of discharge planning to have this assessment done. We know that most patients are at risk for decompensation during the time immediately following discharge, leading to suicide and or readmission to hospital. So proper discharge planning sets the patient up for success. If the patient already has a mental health therapist or psychiatrist in the community, no PDFU, or for those of us who are not familiar with this term, post-discharge follow-up plan, is created. However, the existing treatment providers do need to be notified upon the patient's discharge to plan for a successful and seamless discharge. If the patient has no pre-existing service providers, the inpatient social worker will complete a PDFU, so again, post-discharge follow-up plan, ideally pre-discharge, and send it to Access 24/7, who will book a referral for a follow-up care to a receiving mental health therapist. The therapist will contact the inpatient social worker to discuss discharge planning for that patient, or if done upon discharge, the therapist will contact the patient within 7 days of discharge to introduce themselves and assess the patient's level of risk. If the patient can wait for their already booked initial visit, they will. If there is an increased level of risk, the therapist would book the patient in sooner. Family will be notified sooner and be more involved in transition and discharge planning. And finally, stronger connections can be made with patients' primary health providers by using the guidelines from the Primary Health Integration Network from the Home to Hospital to Home Transition Project. This includes confirming with the primary care provider of their connection with the patient, notifying the primary care provider of admission, involving the primary care provider in transition planning that includes referrals and access to community supports, the transitional care plan, and follow up with the primary care provider upon discharge. So patients will be identified for the Almost Home initiative during rapid rounds based on the following criteria. The patient will be at the contemplative stage of change or higher, although some individuals at the pre-contemplative stage of change will also be considered. They are awaiting a transition in care or have been identified as needing a different level of care, have a LOCUS score of 4 or less, and have a physician's order for enrollment in the Almost Home initiative. Situations that may not warrant enrollment for patients include primarily PDD diagnoses who are waiting for placement, accommodation, or individuals likely to have a short stay. So bringing all of this information together in this workflow should give you a sense of how the LOCUS tool will transition into the Almost Home initiative. So upon admission, the LOCUS tool is scored by our allied health coworkers, which can be either a social worker, occupational therapist, or a psychologist within 7 days. The patient will be identified as ready for discharge or a transition in care, ideally 2 to 4 weeks beforehand during rapid rounds. The physician will enter the order into the Almost Home programming on the green non-medication order sheet. The social worker or other allied health designate will score another LOCUS at that time to confirm that the patient's score is 4 or less, indicating that their care needs can be supported from a community care provider. At this time, a PDFU, or a post-discharge follow-up plan, will be initiated if one is required. A designate from the care team will speak to the patient about service options post-discharge that would best meet the needs of the patient. The care team will then inform the patient's designate, support people, and primary care provider in the community for seamless discharge planning. So in closing, we need you to continue doing what you do best. Advocate for your patient's healthcare needs to the team and gain an understanding of the language of the LOCUS tool as it relates to patient care. Being fluent in the LOCUS language will help you to identify patient progress, liaise with community service providers in transition planning, and allows you to advocate for the needs of your patient from a systems perspective. Additionally, it will assist you to identify to the team which patients may be good candidates for the Almost Home initiative. We need you to support patients with the Almost Home initiative to enhance patient engagement on the unit and in their care. This means you are enabling patients to begin to develop the skills to reintegrate back into the community. So this concludes my presentation. For more resources or information on the LOCUS tool and the Almost Home initiative, you can contact your unit manager or CNE designate. Thank you.